So dear students, we'll discuss a image today which you might not have seen regularly, but post-operative image actually, post-major surgery image. Let's see that and identify what is it. It's very interesting. See that what this image is. See that here esophagus, you can see that. See that esophagus area, you can see the colon here. Colon is come like this. See that colon is come like this. So look at that. You can see the house elevation going up like this. So this is probably contrast X-ray to delineate the esophagus and proximal GI. Mainly it is a contrast X-ray, of course. Barium sulfate solution is used. You know that barium sulfate. Now we use micro barium sulfate solution. Olden days barium sulfate powder used to be, which you have to mix with the water and ask the patient to swallow or drink. In a barium swallow, thick paste is used. In a barium meal, liquid is used, and it is asked, the patient has to drink. Now remember, barium sulfate, barium is the radiopaque, whereas in sulfate media, that's important, not barium phosphate. So the barium phosphate is a rat poison. It will cause the liver damage and kill the patient. Whereas barium in sulfate media is inert, it won't get absorbed. In barium phosphate, barium is the toxic, but it gets absorbed faster and completely. So barium phosphate is not used, only barium sulfate is used. So that is for your kind information. So this is a barium study contrast. Currently, of course, other newer contrast agents are used for imaging in this contrast imaging of the GI. Gastrographin is used, oral other contrasts are used. Iodine contrast agents are used through orally. But traditional barium, microbarium sulfate, microbar it is called as, it is of exactly. Barium sulfate is used, not barium phosphate, because barium is one which is radiopaque, it is also toxic to the liver. So barium phosphate is a rat poison, should not be used. So barium sulfate media is inert, so it gives a contrast and we don't get absorbed, so it is very safe. So they just want for your information. So micro crystallized barium sulfate solution is used. Newer contrast agents also used, of course. That is for your information, because many times may be asked in Viva, Oxy or MCQs may be asked, which is the agent which is contrast, which is toxic also. Why barium phosphate is not, nothing other than rat poison, lethal to the liver. And so here you can see that Coscuro essentials, that other detailed examination of this esophagus you have to do, and other conditions where you do all the things are mentioned here. Coscuro appearance of diffuse and segmental esophageal, other possibilities. So either it is a esophageal spasm with the Coscuro appearance, or maybe colonic transposition as a esophageal substitute. It is for esophageal substitute. That is the point you have to remember. So remember, esophageal substitute means when mainly in the carcinoma esophagus or corrosive stricture, often mainly carcinoma esophagus, when it is operable, esophagus is removed. Many times total esophagectomy is done. Then you have to use a conduit to replace the esophagus as a function of the esophagus, anatomical and functional, of course. So usually either stomach is used, then it's called as gastric conduit to esophageal substitute. Sometimes stomach, because growth is in the lower part, stomach may not be amenable to get adequate length and pull it above. Then you have to use a colonic transposition. So usually left side colon is used, often right side colon also used. Occasionally jejunum is used, because jejunum is not a good conduit to stay up. So gastric is good, colonic is the next option, jejunum is the last option. So they are called as esophageal substitutes. Another thing here you have to remember, where you will place. In the same place as esophagus, it is the posterior mediastinum, or sometimes in the under the in the anterior mediastinum beneath the sternum, you can create a cavity. Good space is there, potential space is there that you can create there, and occasionally in the subcutaneous plane you can put it so that you can feel the colon conduit there. So commonly posterior mediastinum will put it. Sometimes in corrosive strictures, because the adhesions is so much, you won't be able to remove the esophagus. You won't get a plane. If you try to get a plane, it will bleed to death. It's impossible. You will injure so many structures there. In such a situation, you put it as a retrosternal or anterior mediastinal place, or under the skin as a subcutaneous plane. So of esophageal substitute, what are the different substitutes? Gastric conduit, colonic conduit, jejunal conduit. Commonest is gastric, next is colonic. And then maybe like colonic again, left is common, often right. Right side, right half colon or left half colon like that. And jejunum rare. And placement you have to remember posterior mediastinum, anterior mediastinum under the sternum, and under the skin, subcutaneous plane. This is three commonly posterior mediastinum is used. Sometimes when you won't be able to get a plane there in the posterior mediastinum, then anterior mediastinum, retrosternal area. So like that, it is a very conceptualized esophageal substitutes. So colonic transposition is one of the esophageal substitute, of course. Common thing is gastric and jejunal. Common is gastric, occasionally jejunum. So gastric, colon, jejunum. So this is exactly orderly. It is used either posterior mediastinum, transpleural, retrosternal, or subcutaneous. I already told different places where it is. These are the basic points which you have to remember as an undergraduate student, because maybe ask as a short note or mainly MCQs, Oxy or NEET exam via MCQ. They will also meaning you should have that. Commonest is remember gastric. Next common is left side colon, and then right side colon, then lastly jejunum, not very common. It is not, it won't take up well. That's right. And posterior mediastinum is a common area, transpleural, then next of course retrosternal, rarely subcutaneous. So these are the points which you have to remember when you consider esophageal substitutes, which is a common. So please go through my manual of surgery, chapter esophagus for further reading, where it is clearly given esophageal substitute as a topic under carcinoma esophagus. So it is a substitute for the esophagus. So this is the type. So that will give the clear idea about that. So you can write a short note, you can write Oxy, we can also write MCQs, answer different MCQs, with the different permutation and combination may be asked, which you will be able to answer. If you read my book in the manual of surgery, chapter esophagus, will give a clear idea about this topic as such. And different surgeries, I am not going to that. Esophagus, Ivor Lewis operation, Weringer's operation, the palliative one, and McEwen three-phased operation, left abdominal thoracic approach, that is a sweet approach is called as. You can always read my book for this in detail carcinoma esophagus, different approaches, manual of surgery. Detailed technique, you can go through my operative surgery, which is for UG is not necessary, but for postgraduate it is useful. And these are different approaches will be asked as the MCQ question you need to know. So students answer the MCQ and I will put the right answer later, and I will acknowledge your answer, and I will give the other explanation about that also. And meantime, I request everybody to subscribe my channel, and also request you to tell your friends and colleagues to subscribe my this one for daily lecture, daily MCQ, daily quotations. Everything is interesting to enlighten our surgical different topics. So I have a great idea about surgical surgery as such. So please, percentage of curable esophageal cancer is 20%, 40%, 50%, 60%. Another MCQ is Weringer's transhiatal esophagectomy is either curative, palliative, done for corrosive injury, or a minor procedure. Find out the right answer. I acknowledge you. And please, again, I request, again request you, please subscribe my channel in the YouTube, please. And quotation of the day is again important, interesting. Older you get, the more you choose calmness and distance from disrespect. Probably people like me, I'm 61-year-old. So I prefer this quotation to my way of life as such. Very important to keep your things, keep your mental stability. So students, please go through my SRB's clinical methods in surgery, current edition, which gives in detail about the clinical exams, all chapters, including X-rays, other images, basic instruments, specimens, and gives a very lot of photographs are there, figures, illustrations are there for your benefit. Detailed clinical methods and case sheet rating is there. That's very important for clinical surgery. And manual of surgery, current edition, gives a detailed discussion of all topics, specialties, urology, cardiothoracic, and other chapters, including instruments, operative surgery specimens, as per CBMA syllabus in detail for your knowledge, exam, theory, clinicals, everything. Please go through that. And of course, my operative surgery book in the 2 volumes is very useful to understand the very operative procedures with the step-by-step technique. And my atlas of tissue approximation, small book, with a video. All this contains a video of the demonstrations of different things. It also gives a suturing technique very briefly, very nicely, and with the principles. Please kindly go through that. And my SRB surgery insights and YouTube different channels. My website. You can please subscribe. That will give a lot of information, and it will be very benefit for all students. And please subscribe my SRB surgery insights of different modalities for understanding better knowledges and subjects, because best topic different versions are there in small topics in the website, and this is the QR code for the same. So students, I hope you understood this lecture very well. Again, I request everyone to subscribe my channel, and request of your friends to subscribe my channel. So thank you so much.